So hi, everyone. Troy Jorgensen, Program Manager here for Project Echo Nevada.
Hi, good afternoon, everybody. Mordechai Levy, I'm a geriatrician. And I think the interesting fact I will share for today, I just found out about it. I was reading a book and they talked about another book that Colin Powell wrote called something to do with a force multiplier. And so the first time I'd heard about a force multiplier was Echo. So this is the second time I'm hearing about it. So, I'm gonna go check out that book a little later. Nice to see everybody again today.
Hi, everyone. Welcome to one of our final-ish sessions of ECHO. I'm Teresa. I'm an infection control nurse at a skilled nursing facility and also an assistant professor at UNR. I already said I'm running out of fun facts about myself, but I had a fantastic weekend this weekend. So it was just beautiful weather and it looks like it's also really beautiful outside. So I'm gonna look forward to biking home for my commute.
Hi, I'm Mark Pandori. I'm the Laboratory Director for the Nevada State Public Health Laboratory and an Associate Professor of Pathology and Lab Medicine here at University of Nevada, Reno School of Medicine. A fun fact about me is I like to drive very fast, but I have not received a moving violation in 27 years.
Hi, I'm Steve Matlis. I'm the safety officer here at University of Nevada School of Medicine. Fun fact, if you've got an N95, you should not put a surgical mask on underneath it. Surgical mask can go over it as an extra layer, but not underneath. Thanks.
Hi, I'm Regina Neal. I'm the QI coach, and I don't have any fun facts today. Sorry. Although I did make a great Thai shrimp curry last night for the first time, and it was very exciting to be able to learn that technique.
Hi, I'm Steve Phillips, medical director, and I guess still nursing a bummer lamb. Or I guess I wasn't on last week, so I didn't tell you that one of our lambs stopped eating on its own, so brought it into the house. Grandkids got to give it love last weekend, and on Saturday I was able to reunite it with its mom. So, and it's still surviving, so that's cool.
Hi, my name is Neha Sharma, and I'm the program coordinator for Project Echo Nevada.
Hi, everyone. My name is Nathan Militante. I'm also a program coordinator here for Project Echo Nevada. I hope everyone had a great weekend, great weather we're having right now.
All right, thanks everyone. So yeah, that's our team here today. I've seen a number of you doing it already, but if you can help us out and write in your name, your credential, and your location through the Zoom chat box for our records, as well as respond to the poll, that helps us just have good records for these sessions and make sure that we're recording your attendance so you can get your reimbursement. So we'll pull up our Zoom polls here today, 2 questions for you, and then actually one that you'll send in through the chat box. So first question, do you have a trauma screen for your residents? Responses there are yes, no, or unsure. And then question 2, which of these best defines social isolation? So is that being physically separated from someone else, feelings of loneliness, quarantining, not having family or friends, or none of these? So if you can send your responses through the poll there, just click on the poll that's on your screen. And then in a second, we'll move on to the chat question once we get those all tabulated. All right, number of responses coming in through the poll already. So if we can also respond to this chat question here. So what challenges to vaccinating your staff are you still experiencing? I think we've talked quite a bit about some challenges that you all are having with vaccinating your staff, but if you still are experiencing any, please share that through the chat box.
This is Julie over at college. I'll jump in. So the challenges I think that we're having is being able to get them out and, to either their responsibility to go get it because they're frontline workers and can probably get into any of the locations. It's just getting them out there. I think some of them are still kind of relying on us to do that. Or to set it up. So it's not going to happen at the facilities anymore. So we're trying to get them to the different locations as best we can with any acknowledgement that they're frontline workers so they can get to the front of the line here and get it done. Now it's just a matter of them getting out and standing in the line, and there's not a whole lot we can do because we gave them that option when we were providing it here and they didn't take it. And then I know that's not the question, but the information still remains that residents all got vaccinated that first time around. And since then we have all residents coming in and no one's vaccinated. Of course, that whole thing is happening too still. So that's a huge problem, is that follow through of new residents and continuation. So.
Thanks so much, Julie. Really appreciate that. Yeah, Michelle kind of sharing similar things here, saying we still have employees who do not want to be vaccinated. And then we also have employees who want to be vaccinated, but now they're done with all of the clinics for vaccination. So yeah, kind of some common issues here. Let's end the poll real quick and then keep talking about this vaccination question here. So the responses to question 1, do you have a trauma screen for your residents? 53% of you said yes, 19% said no, and then 28% said unsure. And then question 2, which of these best defines social isolation? Highest response was 44% for feelings of loneliness, 34% for being physically separated from someone, 16% not having family or friends, and 6% quarantining. So thank you all for responding to that. So yeah, back to our chat question here. And you can write it in the chat box, or you're free to unmute yourselves as well. Jeremy Moore says,
Troy?
Yeah, go ahead.
Sorry, I just want to let it, we will be the video will share the answer to number 2, so we will get to that for everybody. Sorry, Troy, keep them.
No, appreciate that. Yeah, so that'll be addressed. We'll get an answer for question 2 there. Jeremy says they don't trust the vaccine even after being educated. We have some staff who want it but can't get it because clinics have ended. So yeah, kind of some common issues here with staff now wanting to be vaccinated, but no more clinics happening to do that. All right, any other issues or comments on this topic?
Hi, Mordecai here. The one thing that I would share with everybody, and I think Regina was on this call too, so if she has any other comments, there was a call at noon. I logged on a little late because I was in clinic still. But this was a very common theme across the country. Everybody has these exact same questions. And we are doing our best to collectively look for an answer. But a lot of these strategies, we're looking to you guys to see what's worked. How have your employees gotten vaccinated now that we're not having these clinics? What other recommendations do you have for, maybe somebody kind of changed their mind yesterday and they'd always been against vaccines. What was it that changed their mind? And so we would love to hear those answers because they could give us all some good ideas on how to approach our own communities.
Yeah, thanks, Dr. Levy. Yeah, June shares a solution here that they reached out to Southern Nevada Health District to look into setting up another clinic at their facility. So June, would you be able to unmute and share, have you had any success with that yet?
Okay, we haven't heard back on anything, but we have both a hospital and a SNF. So either one, I'm hoping they'll allow us to do for the clinic, and then we bring the SNF residents over.
Okay. All right. Yeah, definitely. Please keep this group updated if you have any success with that.
Okay, will do.
Thank you. And then Harold shares, we have a third CVS sponsored vaccine clinic happening this Wednesday. All right, thanks, Harold.
Yeah, Harold, one thought was, you might want to share kind of some of the things that people have been saying with the difficulty of getting the vaccine after that third clinic, so people kind of know, if they're thinking about getting it, this would be a good time to jump on.
And then Vanessa also shares trust and kind of talks about how important that is. So once a trusted associate gives the okay, such as a church, staff member is willing and open to be vaccinated. So yeah, maybe kind of some external sources of trust, and once they give the go ahead, that staff members are more inclined to get vaccinated at that point.
Hi, I wanted to just quickly add a story of success that some facilities can also use. I think really it came down to persistence, but I wanted to get some of our new admissions, the residents, vaccinated, and we were past our third clinic. And I was kept being told by a facility, a vaccine setup facility here, that just make a my chart. And my charts don't work if the person doesn't have an email. And also the way the system was set up, the person had to answer security questions. And they're not security questions where you type in a random response, but like, which of these 5 addresses did you ever live at? And so with several residents, we weren't able to get past these security questions to make a my chart. It eventually led to being able to call. And so if someone's telling you to make my chart and you're having not good success due to lack of an email or not getting past those security questions, I'd highly recommend trying to call and trying to set up appointments. I was able to set up appointments for 4 different people, and they'll hopefully get their first dose tomorrow. So it just really required a lot of persistence, a lot of follow-up calls, back and forth, explaining the issue. And eventually I was able to get through. So I just wanted to recommend that for you all for if you're trying to get some of your new admissions vaccinated.
All right, really appreciate you sharing that with us, Teresa. All right, I think we'll keep moving on here then, Dr. Levy. All right, so onto our case review and discussion. So just a reminder about our case review format that we'll follow here. So we'll have the person present the case, then go to clarifying questions, then recommendations, and then have a nice summary and wrap up. So yeah, I want to give you all an opportunity right now to present any specific patient cases in your facilities right now, or any other questions that you'd like to pose to the group. So please feel free to unmute yourselves, or also you can use the chat box. All right, Dr. Levy, you want to take us to our example case then today?
Sure. I'll read this for us. So we have Ms. Jimenez, 87-year-old woman with moderate to advanced Alzheimer's disease, who lives in a special care, memory care unit. The team has learned her habits and preferences and has identified ways to approach her during care to reduce any struggle and optimize outcomes. With COVID-19, team members all wear masks or masks plus face shields. Sometimes they wear full PPE, which frightens Ms. Jimenez. Also, she is hard of hearing and unable to read lips, so her ability to communicate is now much more limited. The activities on the unit have been significantly reduced, and Ms. Jimenez's mobility has declined. So our case questions for today for us to talk about is, what ideas do you have for promoting Ms. Jimenez's mobility and preserving communication and mentation during COVID-19? Number 2, what solutions might address the challenges with communication when staff are all wearing masks? And number 3, do you have suggestions about optimizing activities for programs during COVID-19? So we'd love to hear all your thoughts on this case with this person living with dementia. I know many of us have patients that may be similar to this, or at least have had them in the past. And so What kind of ideas or what kind of things have you utilized to help answer these questions? Feel free to take yourself off mute or type into the chat.
Hi everyone, Nathan here. Also, please be aware that we have a reactions button on our Zoom call. If you go to the bottom right screen, you can go ahead and kind of react to kind of the questions going on. Or if you have a question or a statement that you want to make, you can actually raise your hand, letting us know that you do want to make a statement during this question. Thank you.
Comment here from Nicole, just saying that communication boards are great.
Thanks for sharing, Nicole. How many types of communication boards do you have?
We have a couple. We have some in black and white, some in color, English and Spanish, and then a communication board is essentially it's a board that has images on it, so that way you can, if somebody has a difficult time expressing what they're trying to say, they can point to the person who looks like they're in pain, or the toilet because they have to use the bathroom. So it's easier for them to point to what they need instead of saying it. But so like I said, we have some in Spanish and English, and I know they have ones that are like magnetic and like have the dry erase function. So for people who are able to write but can't speak, that helps as well.
Thanks, Nicole. Which kind of communication board do you find most helpful for people living with dementia?
I can't say specifically for dementia. The majority of ours that use them have their residual effects from strokes.
Thank you.
Michelle, I see you raised your hand. Thanks for doing that. If you can unmute and share what you'd like.
So as far as promoting mobility and communication mentation, we have RNA, restorative nursing assistants, that will go in and help with patients who we feel are having a reduction in mobility, and they can work with the patients and it gives them a little bit more interaction. And then also we bring them out into the hallway or in the doorways, try and get them to wear a mask if we are negative in our facility, to try and get some communication, some interaction with them, especially if they have dementia and we see that they're starting to have problems. Doing what we can to be as safe as we can to keep them occupied and entertained when they can't do anything. And then our activities department has a whole bunch of things that they're doing. We have room-to-room visits going on. We have a thing that we just recently, one of our activities assistants put up about these hands have done different things. You know, these hands used to sew things. These hands used to, start IVs, that kind of thing. We do dancing in the hallways. We do all different kinds of things, but it's in the hallways and trying to keep the distance as best as possible. Not really many group things anymore, just because we can't, but we're doing what we can.
All right, thank you so much for sharing, Michelle. One comment here from Kelly Presser, just saying, yes, speech pathologists normally have great visual communication boards. They're a good resource. Thanks, Kelly.
Hey, Mordechai here again. Kelly, I was wondering if you were able to share any of the communication techniques that you guys may use at the VA to help communicate those that are having a difficult time communicating.
Hi, this is Kelly. So sometimes we'll use those communication boards that was mentioned, but unless they're designed for dementia, they might be a little overwhelming. So we've even had times where we'll print up a little communication book I just have pictures and words of different things on each page, so that the veteran can either point to something that they need, or might even include something like printing pictures of their family, if it's, you know, one of their common requests that they want to hear from a family member. Our staff just do a very good job also at understanding some of the nonverbal communication of our dementia veterans as well. So I think that's important too, to recognize any nonverbal cues that might signify pain or hunger, that kind of thing.
Thanks, Kelly. Appreciate that.
Mm-hmm.
Yeah. Anybody with any thoughts, feel free to share. So I'll have one last question, and I'll kind of open it up to the other HAP team members for the group. But what are, oh, was somebody trying to say something? Sorry.
No, I think go ahead, Dr. Levy.
Okay. So what have you all learned over the last year about communicating that you want to continue to take forward? Something you don't want to forget because you found it really helpful.
I think the face-to-face communication with the staff has gotten better, and I think it helps us develop a stronger relationship with each other. It helps build that trust and accountability. Honestly, if it wasn't for COVID, I don't know that I would know all of my staff by name. So it's been really nice to just spend that one-on-one time and get to know them. And then they understand how important, you know, if there's a change in policy or a change in process, you know, that they understand how important it is to listen and to ask questions if they don't understand. You know, before it used to be maybe just a team huddle or all staff meeting, but now when things change so quickly, just spending the one-on-one time face-to-face with your staff, I think is really important, that I'm going to continue to do moving forward.
Cool. Thanks for sharing, Nicole. I definitely, guess what I'm hearing from you is, sounds like you've really, you know, individualized each team member, which is really important to kind of helping them realize their individuality within the team. Even though we're in a team sport, we all kind of need to know how important our individual contribution is to kind of keeping up what we're doing and getting to know people person to person is super important. Yeah, and Julie, communication in general, you know, it was a broad question to kind of help you interpret it as you wanted to. But yeah, it could be communication with your patients, your staff. If you found something, communication with your family that you found helpful, that you think the group would benefit from learning from you, we'd love to hear about that too.
I do want to bring up, we're still in the middle of this project, but one of the things, because when we all started wearing the masks a while back, we just haven't finished it, but we're pretty much almost done. I had seen one time on a hospital elsewhere in our country where a physician had taken pictures of everybody and put it on their name tag, because you can't see more than half the face, you know, about who's who. So we started that project here. And especially, you talked about dementia and, you know, the hard of hearing. I think it's even a bigger handicap. I understand, because I wear 2 hearing aids to hear on a regular day. And since we went to masks and I didn't realize how much lip reading I actually did in a day as well until it went away. So being able to be part of that hearing loss situation, and then trying to figure out now people are double masking, which is even making it worse, or a shield where it's echoey. I find myself missing still 50%, if not more, of a conversation, having to ask again to please repeat themselves. So taking that handicap and putting it to the residents and adding a little dementia or what else to the package here is unbelievable on how, and we wonder why people are frustrated or, don't want to do or whatever. I'm able to say, could you please repeat that for the 10th time? And my staff are really good about it, but assuming that a resident hears it and is wrong, because in most cases they don't. So one of the other things we try to do is maybe add these pictures to the bottom of the name tag so that they could see what it looks like and maybe relate the picture better than the face at this point, based on half of the face being covered up. So in my mind, there's a major twofold problem here in communication. So the trust of knowing who you're talking to behind that mask, and now people are wearing shields and every other darn thing. And then, of course, the hearing portion of that, which is, again, from my standpoint, a tragedy.
Thank you, Julie. Appreciate sharing that perspective. I definitely learned a lot from that, so thank you. And then I see there's another. Troy, do you want the chat? I guess I got it. From Vanessa Dixon, answering question number 3. Do you have suggestions about optimizing activities and programs during COVID-19? Smartphones, laptops, tablets, and game consoles offer a variety of ways to pass the time and keep engaged and stimulated. Cool, thanks for sharing, Vanessa. We appreciate that. I guess trying to use the reaction emojis, how many, I guess, just kind of thinking for all of you all, do 50% of your residents have access to some of those technologies that Vanessa listed? You can just use the thumbs up like Nicole did. Cool, thanks everybody. Taking a look at all of them, scrolling through. Great. Any other comments from the Hub team that they'd like to make?
When I was thinking through the question of what do I want to bring forward, it came up in part 3 with Vanessa's response, but I really want to bring forward the access to have video conferencing calls, because I really think it's increased the chance for some of our residents to kind of talk to people who, and more of a face-to-face for people who are not in the area. I have seen people FaceTiming with their relatives in New York or wherever, and I think that has helped with the communication quite a bit. So that's my one technology that when I was thinking through the question, the one thing I want to bring forward.
Thank you for sharing.
Yeah, thanks, Teresa. Nicole also shares another comment here. My residents have really gotten into puzzles. So we spread some tables out, one person per puzzle.
Can I just ask something? So Nicole, so are they in the same general area but separated? So they have at least physical awareness that they're, with people they may know?
Yeah, so our activities room is actually pretty large, and we can fit they're probably the size of like a card table. So we have 3 of those, and so they're spaced out. I have the space to do that, and so I can have 3 residents in there. They're really good about wearing their masks. They use their hand sanitizer, and they're the only ones to work on that puzzle. And then once their puzzle is done, which surprisingly they finish them very quickly. And then we'll rotate. So if somebody else wants to turn to do a puzzle, then we rotate people through that way.
Thank you for explaining that. And do they have interaction with each other, or are they able to like chit chat with each other?
Oh yeah.
Oh,
We
that's
have music
nice.
on. They love it. Yeah.
That's a great idea. Thank you.
Um, I guess Charmaine shares, sorry if I got your name incorrectly. We have one-to-one activities, individualized activity packets, and really hone in on activities that are personalized to the residents to keep them engaged. Yep, great example of identifying what matters to the patient and helping improve their mentation and mobility that way. So great. Thank you for sharing. All right, I guess, should we keep going? Okay, so I'll move on with our data update for today. As usual, I'll start with our test positivity numbers. And so you can see there's a lot less of them in green, so that's really nice to see, but still some turning green that used to be white. So here in Carson City, test positivity rate is 6.1%, Churchill County 5.4%, Clark County 10.7%, Douglas 6.3%, Elko 13.9%, Esmeralda 6.3%, Eureka 12.5%, Humboldt 2.9%, Lander 2.7%, Lincoln 6.2%, Lyon 6.6%, Mineral 8.8%, 9.2%, Pershing 14.3%, and so you can see Pershing has had an uptrend after they were in the white for 2 weeks. So you can, as we all know, we can go back up. So we have to stay super diligent with all of our precautions. Washoe County 7.3% and White Pine 3.9%. And so even though these numbers are going down, this has really still affected a lot of the facilities across our state, across the country, and across the world. I was hearing, I think this morning or maybe yesterday, that we had surpassed 500,000 deaths across the United States. And so I live in Washoe County, and I know that's more people that live in Washoe County. So it's a lot of people. And so these were the numbers from last week, with 14,398 confirmed cases and 823 resident/patient deaths and 21 staff deaths. So numbers definitely not going up as steeply as they used to. 14,466 for total cases and deaths. Just a, still every life matters, but not as many lives lost that have been counted in the last week. And then staff have stayed at 21. So hopefully, I know Steve might have to leave a little bit early, but one of the updates I wanted to give, kind of trying to figure out what would be most helpful for everybody, because there's lots of stuff out there all the time. And so what I ended up coming across was this article, just a news article from Kaiser saying 5 reasons to wear a mask even after you've been vaccinated. We haven't really talked about this, but I thought this list of 5 was really good and really short, hopefully easy to remember. But it's good to remember none of the vaccines we have are 100% effective. They don't provide immediate protection. We're not sure if they prevent the spread of the virus, so we still need to be very diligent. Masks may not protect people with compromised immune systems, and so there's those of us that have other diseases and illnesses or on medications that may limit our ability to get the vaccine or kind of mount an immune system, and so making sure that we're protecting them is super important. And then I know we've heard a lot of things about variants and genetic mutations. Masks protect us from any strain of the coronavirus. And so if anybody's really worried about the variants, just remind them that the mask can help out a lot. I almost wanted to share some information about double masking, but as I was going through the data, I was getting a little overwhelmed myself to make it digestible for everybody. So I'm really happy there's people like Dr. Fauci that says it's generally a good idea with a couple restraints. And then again, Steve Matlish making some good comments with his interesting update today by not putting the surgical mask under the fitted N95 respirator. So any other comments on, and then kind of wanted to leave it updates from the groups, things for the good of the group about COVID-19 that you hope we're talking about today. I have one article to share that Teresa shared, but we can get through that pretty quickly. So just kind of, again, want to see if anybody has any other COVID-19 updates they want to share with the group.
Yeah, there were a couple of comments, one from Misty back to our topic on activities. So Misty shares, we offer doorway bingo, refreshment cart with music, and snacks in the afternoon. We have one-to-one visits and we hand out activity bags. We offer daily chronicles in the morning as well. Excellent, thanks for sharing that, Misty. And then a comment here from Nicole talking about testing and staff who was vaccinated. So we tested our staff on Friday for biweekly testing. 2 staff members who received both doses of the vaccine, last one given on January 19th, tested positive on February 19th. PCRs confirmed those positive tests as well. And then I see, Steve, you raised your hand. If you want to unmute, please go ahead.
And don't forget, it's, you know, it's flu season. So COVID is not the only reason to wear a mask.
Yeah, great point there. Thank you so much, Steve.
So thanks for sharing that comment, Nicole, about the positive COVID-19 test even after vaccination. So even though we are safe, or whoever is safe by getting vaccines, we can still make other people unsafe. And so super important to keep that in mind. Mark Pandora, any other comments on Nicole's comment?
No, I don't have anything to add to that. Sorry. Thanks.
Thank you. Just wanted to give you a chance. So again, we'll kind of keep it quiet for 30 seconds or so, see if anybody has any other COVID-19 updates they'd like to share or discuss. And again, it can be anybody participating, any of the Hub team members, whatever, open forum.
Nicole, Michelle kind of asking a clarifying question for you here. Were the positive employees ever positive in the past?
They were not.
Are they symptomatic now?
One is asymptomatic. The other one thought it was allergies, took an allergy medication, felt some relief. And then we did her testing as soon as she came in, and then it popped positive. So we did the PCR to confirm, and we got those results on Saturday.
Which vaccination did they get, Pfizer or Moderna?
Pfizer.
Awesome. Thanks, Nicole. Thanks for sharing that additional information with us.
Yep. Yeah, sounds like nobody severely sick, Nicole.
Yeah, and hopefully, I mean, I guess that's what I've been hearing about the vaccine is, even though it's not a cure, but if you do get it, I believe that your symptoms are just less severe as somebody who's not vaccinated.
Yeah, that's my understanding as well. All right. So thank you everybody for your participation so far. So I just wanted, Teresa shared this article with me, so I thought I would share it with you all as well. Again, this has to do with all of the data that we report. And so the CDC is letting us know all about the data. And so it's kind of, this is from the Vaccine Safety Monitoring, the VAERS. So people kind of voluntarily submit in vaccine adverse event reporting system. People can voluntarily submit to this. Many of us may have done that ourselves after we got our vaccine. And so this is kind of letting us know how many people and kind of some of the adverse events that happen with after the first month of vaccination. So during this period, there were over 13.7 million vaccine doses administered. 8.4 million or 61.2% were administered to women. They received almost 7,000 reports of adverse events after vaccination. 90.8% were classified as non-serious and 9.2 were classified as serious. They do have information about those that are not in long-term care facilities, but just because of the population that we care for, thought I would share that information. So of all of those adverse events, 150 or 2.1% of the reports were submitted from long-term care residents. 58.7 were after the Pfizer and 41.3 were after the Moderna. One thing to keep in mind is this only includes one dose of the Moderna vaccine because the Moderna was approved a couple weeks after the Pfizer. And so most people had not received that second dose of Moderna if that's the vaccine that they were getting. The median age of the people that received the vaccine was 83. And 61% of the reports were from women, and 122 of the reports were serious adverse events in long-term care facilities. Of those adverse events, 78 were deaths that have been reported and investigated. More than half of those occurred in hospice care or do not resuscitate status patients. And this is just some information about the death certificate data. So essentially only had information on 22%, and it seemed to be a very all-cause mortality type of picture with cardiac disease, dementia, pneumonia, failure to thrive, lots of different diagnoses. And then still waiting on a few more information to get more, and they'll update that at that time. Deaths occurred 0 to 20 days after vaccination, with the most common being 2 days after vaccination. This is a table of the things that people complained about with regards to side effects after getting the vaccine. Again, they only had one dose of Moderna to report, whereas they had dose 1 and dose 2 of Pfizer. And so when you look at both vaccines, just as far left column, you know, almost 71% of people had pain at the injection site, 33% had fatigue, 30% had headache, 23% had myalgia, 11.6% had chills. Sorry, I got to move this, keep moving this bar. Injection site swelling, 10.8%, joint swelling, 10.4%, and nausea, 8.9%. Again, and you can kind of take a look at the numbers across the different vaccines. And again, Moderna only had one dose. So I thought that was some interesting information to share with regards to kind of the things that people might be complaining about after vaccination. I know that could be a concern when people are hesitant. And so now we have some good data showing exactly how, you know, over 13 million people across the United States responded to these vaccines using the VAERS reporting system, which does have its own limitations, but is a good resource nonetheless. So happy to answer any questions, or if anybody has any comments, feel free to share those before we move on to the video. So again, the data shows that this seems to be a very safe vaccine. There are some local reactions, but again, this is much better than getting COVID-19 and ending up in the hospital or potentially dying. And so always keeping that perspective as well is super important. Cool. Well, thank you all. Troy, do you want to carry us through this part?
Sure, yeah, thanks, Dr. Levine. Yeah, so we'll get into our didactic and the video for today's session on social isolation during a pandemic and after, with our presenter being Paige Hector. Learning objectives for this one are to discuss the impact of social isolation and moral distress on residents and staff, and define social isolation and loneliness, back to our poll question from earlier. So I will pull up the video here and we will watch through that and then have some discussion afterwards.
Hello and welcome to the webinar titled Social Isolation During a Pandemic and After. My name is Paige Hector. I will be your speaker for this session. When I was asked to prepare this topic, as I often do, I become curious. I start thinking, well, what is the nature of the problem? What is it that we are really dealing with, and how might we go about some ideas for improvement? So much like this little guy here, I just love this image with his little magnifying glass and looking so intently. That's what I feel like, well, what really is the problem that we're dealing with here? So I asked a lot of questions. So isolation, social isolation, well, what is it exactly? Is it a new problem? Is it an ongoing or something different problem? What are the contributing factors, and what resources do we have to address it? And what else do we need? First, I'd like to take you on a quick side trip. I'd like to introduce you to my sister, Shannon. Shannon's a high school special education math teacher, and we often talk about the similarities between education and healthcare. So I recently asked her to make a list of the challenges that she faces as a teacher. Sometimes I find it very helpful to step outside of my world of healthcare and long-term care and look at ideas from a different perspective, through a different lens, so to speak. Oh, here's my sister's list. So as a teacher, on any given day, she is dealing with technology challenges, as all of us are, fatigue and burnout, herself, her kids, her children, the children's families, issues around housing and food insecurity, so social determinants. There's a lot of issues here, and many of them overlap with healthcare. And the analogy I want to make here is, well, all of these impact her ability to provide the best education to her students. Would we expect her or any teacher to solve all these problems? Well, of course not. That would be ludicrous to think that, right? And it's the same idea with our nursing homes. We have so many issues going on right now, so many factors and challenges. There is not one administrator or director of nurses or leadership team, medical director. There's not one person individually that can solve all of these issues. What we can try to do is make a difference. So let me delve a little bit more deeply into our world of healthcare. So in May of 2019, Dr. Nazir, the immediate past president of AMDA, he wrote a wonderful article, and I love the title, "No One Cares When Planes Don't Crash." And he listed things much like the list that I just showed you with my sister. This is an abbreviated list of certain: rising patient acuity, disproportionate reimbursement, dissatisfaction and turnover as a result, it impacts quality of care, and other things that adding to the discouragement and demotivation of staff is the survey process and focus only on deficiencies, media reports, and boy, aren't there a lot of those right now. Negative processes like legislative hearings and lawsuits, of which I think we're just beginning to get a flavor of in this pandemic space. Everything focusing on mistakes. There's nothing that says, look at the wonderful care. There's very little, or maybe there's going to be more of those stories coming to light. The wonderful care, the good things that are happening in our nursing homes. So point out the date again, May of 19. This list from Dr. Nazir was before the pandemic, so we can certainly add a whole list of things related to this added complication. Social isolation is certainly one of them, but again, there's not one person that can solve all of these together. In the history of post-acute and long-term care, there has never been a time that we have needed to come together more than we do right now, because individually we do not have the bandwidth to address all these issues. It's going to require multi-level strategies and collaboration, just like what IHI is doing in conjunction with the ECHO Institute to bring these webinar series to you. So we can still affect change. At the micro level, individual residents and families, we can screen for trauma. Providers can screen for trauma. If we identify residents that are at risk or highly or experiencing trauma, we can refer them for in-depth assessment and treatment when necessary. At the facility level, which I call the meso, the middle level, it's a facility commitment to operationalize trauma-informed care principles, to train and mentor and coach staff engaging in these practices of trauma-informed care, collaborating with professionals. So when we identify residents that are at risk of or being traumatized, that we have a host of experts that we can engage and get involved to help these residents, because very few post-acute and long-term care facilities will have that resource in-house, that level of training and experience and expertise. Ultimately, what we're trying to do is achieve sustainable culture change, not just change related to the culture of the pandemic. The definition of emotional and psychological trauma is the result of extraordinarily stressful events that shatter a sense of security when we feel helpless. It often involves a threat to life or safety, but really it's any situation that leaves the individual feeling overwhelmed and isolated. And the more helpless or frightened one feels, the more likely they are to be traumatized. Adding to that is the work of Dr. van der Kolk. He's a psychiatrist and trauma researcher, and he talks about the virus being a pre-traumatic condition based on two core variables. Number one, immobilization, literally the inability to move around, being quarantined or sheltering in place. That certainly describes all of our residents right now, right? They're in their rooms, in their little apartment. They can't go out to communal dining or do activities or even out in the hallway for most purposes. Unpredictability is not knowing what's going to happen next. We don't know what's going to happen tomorrow, and even within the day, things are changing as regulations, and we learn more. So protocols change, recommendations change. So when those two variables are present, unpredictability and immobility, the vulnerability to becoming traumatized is great. And again, I keep pointing out that we're talking about residents in this webinar, but I always approach things from the lens of what about staff? This describes staff as well. So a little bit more in depth here with this idea of social isolation. It's actually, there's two issues here, social isolation and loneliness. The social isolation is the objective physical separation, literally people being quarantined in their room or to their homes. Loneliness is the subjective feeling, the subjective distressed feeling of being alone or separated. So these two can exist independently from each other, or they can exist together. So a person can be around other people and still feel lonely. A person can be alone, but not feel lonely or distressed whatsoever. So we really do have to know what it is we're dealing with. Either way, when a human being, when a person loses a sense of connection and community, the perception they have of the world changes. It becomes more threatening, mistrustful, or scary. When we feel those states of distress, that is what triggers the biological defense mechanism that we all know as fight, flight, or freeze. So when our bodies and our minds tell us threat, 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 we're unsafe, the world is unsafe, our environment is unsafe, our body automatically does this. It picks fight if we think we can fight off the threat. We run away if we can't, or we freeze, we dissociate, we shut down. So I'd like to put this in context of our residents, that if a person is coming across the staff as non-compliant or combative, it could actually be that the person has engaged in the biological defense mechanism of fight. That person is struggling to regain or hold on to any semblance of being in charge or being in control. The flight response could appear to staff as resistance to care, uncooperative. It could actually be that that person is disengaging or withdrawing. In a sense, they are running away, they're fleeing. The freeze state might come across to staff as a resident who is very passive or unmotivated and does not care. And it could be that that person is simply shut down, has dissociated, and is just giving in to people in power because they can't run, they can't fight, they freeze. I really appreciated the work of Dr. Nancy Peterson, and she says that we need to identify people who are most prone to suffer from social isolation and loneliness and those who would benefit most from intervention. The interventions for social isolation may look very different from interventions for those who feel lonely. So there's two different phenomena going on here. What they do have in common are the risk factors associated with both: high blood pressure and heart disease, obesity, immune systems weakened, depression, anxiety, and cognitive decline. So all of these things, I think intuitively, we're like, oh yeah, of course social isolation would do all of these things. So what I'd like to hope or think that we're doing as staff is incorporating this in our clinical discussions, talking about when our residents are experiencing a change in condition, that we're asking questions. Are they isolated? Of course, they're isolated, but are they feeling lonely? Are they suffering ill effects related to the distress of being isolated and feeling lonely? Are they experiencing touch starvation? In other words, skin hunger? Literally, when physical contact is limited or eliminated, we can experience touch starvation. So instinctively, as people, we want to touch people. We want to hold and hug and caress. And we can't do that right now. And there's incredible fear around that. And that starvation increases our stress and depression, anxiety. And what that does is triggers the defense mechanism. So really what's happening is that people are in a constant state of arousal, of anxiety. Okay, our bodies are saying threat, threat, threat. It's constant, right? It's around us. It's in our communities. It's every time we as staff go out of our homes, go into work. So all of these things impact our physical well-being, our physiological well-being, and can also lead to post-traumatic stress disorder, PTSD. And even if it's not diagnosable PTSD according to that criteria, it could still be PTSD-like symptoms. So in my work across the country here, I've been having some dialogues in various groups, and we've been talking about, you know, when the pandemic, I'm not even sure the right languaging here, ends, stops, goes away. Do we believe that once we can touch, hug, and hold the people, do we believe that the negative effects of isolation are just going to disappear? I don't think I do, because the fear that has literally been ingrained into us and for survival purposes, it's not just going to go away. So I think we need to be considering as nursing home staff, what is it going to look like when we can eventually re-enter and re-engage in whatever normal society looks like next? I do like this quotation from Dr. Mocktinger, and he says, my framework for thinking about this is that there are two pandemics, one caused by the virus and the other caused by the trauma and stress associated with the pandemic. He makes the analogy of a natural disaster after which we see increased morbidity and mortality, depression, anxiety, suicide. All of these things happen after natural disasters. The pandemic is no exception. The pandemic still can see increases in all of these. And I'd like us to think, you know, as the weeks and months go on, years perhaps, the people that we receive that come to be with us for post-acute care or to live in nursing homes could actually be suffering from these as well. He talks about there's a predictable second wave of death after exposure to mass trauma. So knowing all of this, what do we do today? How do we mitigate the effects of trauma and social isolation? Well, one of the things, if you're not already doing, is screening for trauma. This is a screening tool. I personally recommend that the National Work Group of Trauma-Informed Care that I've been participating in for a couple of years, this is probably the one that I think most of my colleagues would recommend as well. It's the Primary Care PTSD Screen. It's a 5-question questionnaire, and this is a screen, folks. It is not an assessment. So when we screen residents and they come up that it's indicated that, yes, they're experiencing trauma, the next step is we have to have a plan.
Yeah, right up here in Cheyenne. But anyway, they have a sister facility at the hospital.
Intentional about the tools that we.
Yeah, and so anyway, she.
Julie, we can hear you.
Comes next. We have to have follow-up action steps, protocols, and policies. The same with this tool. This is a tool, a colleague of mine, courtesy of Dr. Barbara Ganzel. It's a supplement to the tool I just showed you. So basically what this one does, it's looking at the current symptoms, the signs and symptoms of post-traumatic stress according to these categories. So look there on the left, it's possible delayed emotional reactions, physical, cognitive, behavioral, and existential. So as we consider, how do we talk about these things? What do we do as staff? How do we incorporate this into our clinical operations, our day-to-day work? You know, one of the things you can do is copy and paste this and create a worksheet out of it. It can be used as a direct screening tool where we talk with residents and ask if they're experiencing any of these things, because not all of these things are on that other tool I just showed you, the Ptsd 5. So this is a supplement. It can be used as an indirect screening tool as well. If you notice there on the right-hand side where it says source. So if the resident is not cognitively capable of answering these questions, perhaps a staff member or eventually families can be able to help. But again, please don't introduce something like this until we have training in place. We know what we're going to do with this information. Where will it be housed? How does it incorporate into the care plan? So we have to work it into our workflow. We need to be talking about the unmet needs. We need to be asking residents about this. I also believe that staff, my work is a lot with staff now as well. So considering the unmet needs and incorporating this again into our work and our clinical and discussions, generally speaking, about residents and what they're experiencing. So here's one of my favorite resources lately. This is from the cupofempathy.com. The creator of this tool is Marianne Van Dyke. She is a nonviolent communication expert and trainer. This is a free download. Go to that website, you can get it. If you'll notice this side here, it says needs. So as human beings, we all have all of these needs and all of these categories. On the back side of this tool are these categories. So notice on the left, the first three columns are feelings when my needs are fulfilled. On the right, you'll notice the little orange or yellowish colored line at the top. These are the feelings when my needs are not fulfilled. So think about the residents in your facility right now. If their needs are not fulfilled, are they feeling pain, wretched, lonely, hurt, hopeless, powerlessness, panic, overwhelmed, irritable, anxious, startled? Look at all of those on the right. Now, when they are fulfilled, are they feeling amused, joyous, open-hearted, bright, calm, refreshed? So it gives us the words around, like that little guy in the beginning, the curiosity part. This is the languaging around the unmet needs, the emotions that maybe many of us didn't have training in the beginnings of our careers. Social isolation needs to be included in ongoing disaster planning. This was a huge point that I've been making lately, that the distress of the pandemic, it isn't going to just stop when the pandemic ends, whatever it looks like in the next year or whenever. I don't even know the time frame. So we need to be adopting and sustaining a culture of trauma-informed care, of which looking at the experience of social isolation and loneliness is part of it. So we need to be problem solving as we re-enter community life, community or life as usual. What might be some issues and challenges? The lingering effects of these sorts of traumatic experiences and the fears. What do we need to be prepared for? I will always try to incorporate things into a lens of process improvement, not just performance, but process improvement. The tasks, the things that we do day to day. So process improvement around trauma-informed care. I'd love to see task forces in each of the facilities, and it's not just one person or department. It includes lots of different people, lots of departments, families, of course, and residents. One idea could be around the video technology, video calls. So obviously most facilities are doing this sort of intervention right now, but if you were to take it a step further, if you were to actually think of all the steps and the processes that go into facilitating a successful video call, what would that process look like? What's the process in your facility as it is right now? When a resident wants to make a video call to a family, how does it work? What's the first step? Who does what, when, and how? What's the oversight? What devices? How do you clean them? What are the barriers? What works? What happens if a staff member is facilitating like this in the picture, and all of a sudden the resident becomes agitated, or the family doesn't know what to ask anymore? They don't know they don't know what questions to ask. What are the conversations to start to help focus on rewarding experiences, to be able to name the grief and the sadness, but also to have movement towards smiles and laughter and new shared experiences. What does staff do if the resident becomes distressed or confused? So when you think about the process, it's not just clicking Zoom, opening it up, and here's your wife, your daughter, your son, your partner, whoever. It's the whole process around it. So I think there's room for improvement and to really maximize what staff are already doing so very well. For me, it comes down to this, is that the pivotal change we are talking about must be ingrained culture change, not just adding a screening tool to a list of tasks or putting a generic care plan on the chart. We need sustainable culture change, not just the culture of the pandemic. So in closing, I want to introduce you to someone that I've recently learned about, Nikki Scott B. Jones, and she's known as the Justice Doula. She wrote a beautiful piece called Invitation to Brave Space. And I'd like to leave this webinar with this poem for you. And I hope that you take this poem and you share it with your staff and think about the culture and the space that you're creating in your own facility. Because truly it is all about staying connected and showing up. Invitation to Brave Space by Nikki Scott B. Jones. Together we will create brave space because there is no such thing as safe place. We exist in the real world. We all carry scars and we have all caused wounds in this space. We seek to turn down the volume of the outside world. We amplify voices that fight to be heard elsewhere. We call each other to more truth and love. We have the right to start somewhere and continue to grow. We have the responsibility to examine what we think we know. We will not be perfect, and this space will not be perfect. It will not always be what we wish it to be, but it will be our brave space together. And we will work on it side by side. To all of you on this webinar and all the people in your facilities, with all of my heart, I extend my deepest gratitude and thanks that we continue to be safe as much as we can to continue to do this work that we all love around nursing homes. And I look forward to coming through this on the other end and hopefully soon being able to see people in person again. Thank you for your time.
So hope you all enjoyed the video. I again learned a lot from that one, and I thought that poem was a really nice way to end it. So there's a 4 or I think 3 resources here, supplementary. These links, when you get the PowerPoint, you can click on these links and they'll take you straight to the website about how to manage social isolation in your facilities in a better way or in a different way. So we have a couple guided questions for our discussion today. What concerns have been raised by residents and their caregivers re social isolation, and how have you addressed those concerns? What ideas have come forward from staff to address isolation? What ideas can you share with others? How do you predict managing isolation in the coming months? Are there any new ideas you are planning to test? And number 4, what are the ideas that interest you from this presentation? What processes do you need to adopt or adapt? So we'd love to hear your all's thoughts on the video or any of these questions. Feel free to take yourself off mute or type into the chat.
We've added some new activities to our calendar for February, and it came from requests from the residents. So even though we can't have large group activities, a lot of the residents are agreeable to do they want to do prayer and meditation on Sundays. And so they'll get a group of 3 residents and my 1 activity aide, and they'll just do mindfulness, meditation, thoughtful prayer. And that's been helping, I think, to address a lot of these issues. And on Sundays, it's a little slower because, all of management's not in the building. And so she's able to spend more time with the residents and kind of bring that sense of calm and peace to them. So that's been really helpful. And that was requests from our residents.
I just want to say that I think that it's really important that we look at the employees as well as the residents. I think even for myself, I was at home for, I don't know, 6 months. Not that the residents aren't the most important, understand that, but I think that especially our buildings that have popped positive and gone through a lot with death and isolation and change and losing partners and teammates and so on and so forth. I think that we have to look at, we all have PTSD as well. And I think we have to take that very, very seriously. I know being a trauma nurse for so many years, you know, that's where my PTSD started. But I think this particular pandemic, even comparing it when we first started dealing with AIDS, this has been a totally different animal. So I just want to make sure that we take care of the team as well. I think that I've seen in some of the buildings where I know the residents very, very well, I've watched them change, but we've done a lot with window visits when weather permits, setting up areas in each particular building where if you have an outside entrance and you can make it happen, the family can win, we're able to spend time with their loved ones and things like that. And I mean, we're doing the best we can. I think activities nationally for our particular company is very, very progressive. And hopefully we'll be able to set up our booths in the next couple of weeks and start actually letting people come back in. I think that's all I have on this right now.
I just want to echo what Bridget said. If we don't take care of ourselves, and it's our staff, but also family members of our staff, if we're not healthy or processing, it's harder to take care of those that we are there to serve. So the residents. So I think that's a really key point, and not to lose sight, it's not just within nursing facilities, it's assisted living, it's group. My 93-year-old mom hasn't really left her apartment in Marin County near San Francisco since last March. You know, and her opening statement every morning or evening when I call her is, I think I'm living in a morgue. You know, and so she's a retired nurse, and she goes, I know it's not a morgue, but there's just no sound. You know, so she hears the door open and she looks down her hallway, you know, just to see, is there a human being there? So, but I think Bridget, you're spot on. It really is important that we take care of ourselves in order to take care of our residents.
Yeah, thanks, everyone. A couple comments here that I want to get to. Wanda, thanks for writing in, saying, I think the trauma is seen by more employees than residents in our facility. Our residents really have no idea of the danger related to this virus. They're thick-skinned and have lived through a lot of types of issues, such as the depression, etc. They witnessed Kennedy being killed. They're not afraid of this virus. They just want to be able to see their families, be able to resume their normal lifestyle as before COVID restrictions. And then Hope says the residents want out. They want group activities. They want shopping. They want some sense of normal life. When we do reopen, staff will need retraining. We've lost all verbal filters.
Yeah, thanks everybody for your comments. And just to comment on next week, we will be talking about emotional well-being among staff as well. So that'll be, thank you for that foreshadowing, Bridget, appreciate that. And then I guess, Hope, I did have one question. Can you just clarify what you mean by verbal filters? And I know Hope may not have access to audio, but so if anybody has any thoughts or questions.
I would say no longer able to count to 10 before responding. Is how I think she's using verbal filters.
Got it. Thank you.
Sure. Yeah, Lisa, I mean, hopefully she can correct if that's not the right interpretation.
Yeah, Hope says that's right.
And so, so Steve, so can you clarify a little bit more what you mean by counting to 10, like making sure that you take time to think about responses?
Exactly, Modi. Exactly. It's kind of like what I ask my grandchildren to do every time I'm around them before they respond on something, or my wife Joanne asked me to do on a daily basis. Could you just take a little time and think about it, right? So.
Thank you. And then I see Hope also said yes, and in-person family one-on-one. So definitely have to, you know, we have a lot of new social norms, a lot of new work norms, and we'll have to reacclimate ourselves to whatever the future is and change. And again, change is one of the things that we can always count on, as we all know. And making sure that we understand the processes of change, like they shared in the video, can be super helpful to navigating those with clear communication. Is if you speak to the process, that can really help rather than the task at hand. So I'm you know, a little biased, but really interested in question number 4. And I know the speaker kind of at the very end talked about the process of telecommunication. I was wondering, and you guys can use the reactions or feel free to take yourself off chat, or I mean, take yourself off mute or type into the chat. How many of you all have written out these processes for tele-video communication with your residents? Is that a protocol that you all have written down, or and again, just type into the chat or take yourself off mute, or the reactions work as well. Cool, thanks, Misty. Sounds like you guys wrote them down. Awesome.
Well, I thought one thing, Modi, that found very refreshing is don't screen if you're not prepared to do something with what you identify. And it is resource intensive. And I thought that was really meaning, you know, she certainly advocated for screening, but if you screen and you meaning either an individual or a facility or a corporation is not able to respond to the results, that also is a disservice. At least that's how I interpreted that. So I thought that was really very cogent on her part. I'd be interested if
so right, Steve, and it becomes a problem. The resources are very hard to allocate, especially when we have such staffing issues. It doesn't have to be a clinician, but what we're finding is that the best practices aren't followed regularly unless we have eyes on it all the time. And so we don't catch things. And then in the survey process, that becomes a nightmare. And so I think that's very true, but also just for the protection of the people. I think that's, I think it's just a really important part of the process. And then to go back to, and now I just lost my thought, guys, sorry. Oh, to formal process for the iPads and everything. We didn't really put anything on paper that I remember, but we kind of have a, you can sign up for it. Families can book their time, activities sort of maintains it. Or you can have a CNA or somebody manage it as well. We did have in one building that I remember months ago, somebody used their own personal cell phone and that blew up into something it should not have turned into because of personal use. So we had to intervene on that. But as far as a formal process across the whole group, I don't think so. But all of the buildings have the ability to do it. I do know that.
Thanks, Bridget. Appreciate the input, and thanks, Steve, as well for that insight that you got from the video. Regina, would you be willing to share some of your thoughts with regards to thinking about a process if people are interested in maybe writing some of these things down?
Sure, of course, you know, that was music to my ears to hear that. And I would just say, I think we've talked about this before, but in order to have reliable use of process, you need to design it so that you can train everyone and make sure everyone knows what they're doing. And so I think several weeks ago, we looked at high-level flow charts, the boxes, 3 to 5 of them. What are the steps? And then each box is a step that is described by 5 attributes: who does what, when, where, how, and you can use that to help create a formal process. And I was just interested in Teresa talking about bringing the video calls into the future, because it so expands the opportunities for visitation for the resident with family who may be far flung. And so now that you've got the experience in using it, might be a great time to think about how to put into place the best process by thinking about what worked and didn't work for you. And I would encourage you all to do that. I think you'll be very happy because you'll get the results you need by design.
We may have done a letter. I can't, it's been so many months ago when we implemented all that it's hard for me to remember everything. But I have to drop, guys, for my next call. See you next week. Thank you.
Thanks, Bridget. Does anyone have any questions about the high-level flow charts or your sense of their utility, or questions about how to do it?
I saw in chat a comment from Misty Montez that they've created a formal process with the mentioned devices that coincides with their visitation process and plan.
So Misty, do you want to say any more about how you did that, or just share a little more about that? And I think that's fantastic. I didn't see it at first.
Yeah, sure.
And while Misty's responding, Sneha, if you could share the Zoom poll before we lose too many more people. The same 2 questions we ask every week about QI to help you think a little bit too about some of these questions. So looking forward to hearing Misty's response as well.
Modi, if Misty's already dropped off, maybe we just have her report out next week, if that's okay.
Yeah, that's fine. Yeah, I think she might be typing in. I think she's still on.
Oh, perfect.
But yeah, anybody else that has any comments or questions? Okay, here I see Misty wrote in. I guess Steve, go for it.
Okay, yes, a team effort they created with the administrator, DON, and social services. That's
and that's the best way to do it.
Yeah.
That's fantastic. Are you using it to train staff or remind them how to use the virtual calls?
Well, she said that they're revising.
Oh, revised it. Wow, great.
As changes have occurred. So I mean, they're using it as a quality improvement.
That's fantastic. That's a great example.
Isn't it?
Yes.
Yeah. The only individual that's missing is the clinician. So where is that medical director? I'll just call it out. So, but that's great.
Misty, thanks for sharing that. Appreciate it.
Thank you all for answering the poll questions. We'll share those results. Okay, we will share those results now. 21% identified a change but did not act on it. 26% worked on an opportunity themselves. 37% made a small change. 16% made a big change. and 16% have not yet identified a change. And then pretty evenly split about this being helpful, some and a lot. So would be super interested to hear from anybody that kind of how they responded for question number one. You know, what barriers did you have to acting on something? You know, I imagine it was a time, maybe an empowerment issue, lots of different things felt too big for your role. And also interested on kind of people working on it with themselves. You know, what kind of inspires you to work on these projects by yourself?